Hi guys. So I was assigned tracheoesophageal fistulas. Now I don't know how to start, so let's just jump in. Um, let's see. I don't even know how to work my computer. Okay, the pathophysiology of this tracheoesophageal fistulas. I'm going to be terming them TEF for the rest of the presentation because it's a really long word and it's a tongue twister. But it is TEFs are birth defects that form during the 4th or 6th week of pregnancy, which is when the trachea and esophagus are starting to form. Now, what happens is an abnormality occurs where there is a connection between these two. And as we know, those are not supposed to be connected. That's a bad deal. So that's why they are very serious and they require medical attention as soon as they are detected. Some risk factors, or what we see a lot in babies who do have TEFs, is that the mother had polyhydramnios. She had a premature birth, and the baby was also a low birth weight. So let's see, there's a lot of types of TEFs. Um, Now, the word atresia you hear very often with TEFs. So what atresia means is an absence of a passage or orifice in the body. And actually, that is Stephanie's presentation, so I'm not going over really what that is. But these do occur alongside TEFs. Um, so we do need to discuss just the basics. So on this little chart here, I don't know if you can see my mouse or not, but we have the first one, the normal anatomy, and then this one is an atresia with the distal fistula. So we have that openness right here, this absence of esophagus, and that atresia is closing off the upper esophagus, and the lower esophagus just continue to grow, but it connects to the trachea. You see one here where the top did connect, but there still is that absence here, so we still are considering it an atresia. There's a difference here. It's just the opposite of this one. It's a proximal fistula. This one is just a regular esophageal atresia, which is exactly what Stephanie's presentation is over. And then there's just the regular fistula. Now, let's see so what are we gonna see with this child? Now, when a child does have a TEF, it's going to manifest it basically instantly upon feeding. Some mothers will put that baby right on their breast. They're going to breastfeed right after delivery. As soon as that baby starts to eat or drink, as you would say, they're going to start presenting with these 3Cs: the choking, coughing, and cyanosis. So those are the clinical manifestations that we're going to see. It depends really whether it's an atresia or it is connected to the trachea at the top on how much this child is aspirating. But that cyanosis goes along with they're not getting oxygen, so they will show hypoxia as well. And we know that hypoxia causes restlessness and irritation. And so this child, what the nurse is going to assess the subjective and objective data that she would see, or he would see, is crying, because they are restless. They are in pain as well. They would have frothy white sputum. They would have, of course, tachypnea and dyspnea. So they would be using those accessory muscles to breathe as well. They would have excessive drooling because that saliva doesn't have really anywhere to go. So they're just expelling it at excessive rates. And they also will present early as in the delivery room with a seal bark cough. That's the term they have given this cough because it sounds like a seal, and I'm not about to try to imitate a seal and make myself look stupid, but that's what they sound like. And so that is a telltale sign of a TEF. So how do they diagnose it? How do they confirm this? Well, most often, the doctor is going to try to pass an NG tube down. Now, if they do have an atresia, or if they have some type of fistula that's going into the lungs, at some point they're going to hit resistance, and it's going to be way earlier on than what they should have. So they're, of course, in normal practice, once we put an NG tube down, you would x-ray to confirm on a child, as Miss Bell taught us. And so they would do an x-ray, and hold on, let me move my big head over here. So you see the red is the stomach, that's where it needs to be, and the yellow up here that is the NG tube, and it goes down and coils up. And I got this off of a video actually. It shows that coiling of the NG tube. So it shows there's an atresia there. That's what that would be actually. And that is the diagnostic test that x-ray confirmed this child has TEF. So how do we treat it? What do we do? Medical management. I'll move my head again. So surgery is emergent on a TEF or an EA even. And most of the time, the surgery that is performed is called an anastomosis. And anastomosis is basically just reconnecting or disconnecting and connecting other passageways. It could be in blood vessels or GI tract or nerves or just anything. In this case, it would be the esophagus back to itself. Now, in the first picture here, you see that the top is a proximal atresia, and then this down here is the fistula they have removed right here from the trachea, and then they went and sewed the atresia to the fistula. They sewed them back together. So they also will use endoscopies or endoscopes during this too, and that is what the second picture is. And you can see right here that carina where they separate into the different bronchioles. This hole that is right above that is what what you would call the fistula. Now that one does look small, but even a tiny hole can be detrimental. So this procedure can be done in one or two surgeries. They could first just remove the fistula and disconnect it, and then they would be put on a peg tube feeding and stuff like that for however long. It just depends on the patient how early this was diagnosed. Has a lot to do with how well the outcome does, or how well the outcome is. So nursing interventions for this patient. So a lot of times the recovery state is about 2 weeks. It could be shorter, it could be longer, but the average that I found was around 2-week long recovery. They will have the chest tube. You see this dotted line on this picture. That is where the surgeon would do a cut here. And you can see in the picture the fistula at the bottom and the atresia up top. But this would be where that chest tube would be afterwards. Now, it's the nurse's job afterwards, and of course, this child would be in the NICU, she'd be a NICU nurse, but they would be responsible for, wound and dressing changes for that chest tube, making sure that it's still connected to suction. So we know that checking for kinks is very important in that. This kid will definitely be on some type of TPN, whether it be a peg tube or an NG tube, depending on how much trauma is in the surgical area. And of course, they'll have IV fluids and analgesics. So all of those things are monitored by the nurse. So those are all of our nursing interventions would be to take care and monitor those things. And the goal for this patient that we're trying to achieve before we discharge them is that they can maintain their weight. So as long as they can maintain the weight, eat and maintain that weight and not be losing um, a whole lot of weight, then they can go home. All right, patient teaching. So of course, in this case, we're dealing with the parents, we're not dealing with the actual patient. So since this is such an emergent and just like a very traumatic event for most cases, they happen very quickly. Um, so we need to try to make sure that these parents know what's going on and keep them in the know. Let them know what's happening. Of course, they're going to have to be, signing consents and stuff like that left and right for these surgeries and x-rays and things like that. But the aftercare that the patient's parents would be giving them is not a whole lot because of the extent of the child's stay at the hospital. They, of course, will go home with antibiotics. And so we would teach them the medication administration um, teaching that goes along with that, finish the entire dose, even if they're feeling better. And then they would also really stress with these parents the importance of the follow-ups. They have a surgical follow-up. They would need to see a pediatrician 1 to 2 days after they leave the hospital, just for a overall follow-up. And they would need to do routine endoscopies for a good amount of their life just to make sure that nothing or different illnesses don't occur, because these children are at risk for specific illnesses. And the prognosis, so children who do have TEFs that go untreated or go unnoticed, which is pretty uncommon, at least here in more well-developed countries, we would notice, if a baby cannot hold anything down. They're puking everything up. Those 3 C's, that choking, coughing, and cyanosis. It happens, along the first feeding. So those going unnoticed is very fatal, and the consequences are. But this defect, it's allowed. It makes itself very well known, and so most cases are identified and they're treated. And if they have the surgical procedure, the anastomosis, we don't have a set in stone rate of survival, but they estimate 100%. If they do have a comorbidity that goes along with this TEF or an EA, it's down to about 80 to 95%. So still, these kids are going to live complete, healthy, normal lives. Now, I did see that a lot of people reported acid reflux after TEFs, but those are pharmacologically manageable. And those are my sources. So I hope y'all understood and y'all could get something out of this. So see you later.